Welcome to GI-ILS7 Portal Circulation and the Anatomy of the Anterior Abdominal Wall. In this session, we'll cover the following learning objectives. Alright, let's go ahead and get started. The anterolateral abdominal wall is a crucial structure that provides protection, support, and functional movement. It consists of the anterior wall, which forms the front portion of the abdomen, and includes the skin, subcutaneous fat, muscle, and fascia. There's the right and left lateral walls that serve as extension of the anterior wall, and it houses key muscles like the external oblique, internal oblique, and the transverse abdominis. The posterior wall primarily is made up of the lumbar vertebrae and its associated muscles. It plays a role for trunk stability and also movement. Functionally speaking, the abdominal wall protects the internal organs, supports our posture, it helps with respiration. It also regulates the intra-abdominal pressures. Pressure controls vital activities such as coughing, sneezing, vomiting, urination, defecation, and of course childbirth. In a clinical application, there's a condition known as the diastasis recti. This is a common condition in which the rectus abdominis separates along the linea alba, and this is oftentimes seen in pregnancy as well as folks that have extreme obesity. On the right is a visual showing you the subdivisions. We have the anterior, left lateral, and the posterior. The anterior lateral abdominal wall is defined by distinct anatomical borders that provide structural support. Superiorly, it's bordered by cartilages of the 7th to 10th ribs and the xiphoid process of the sternum. This forms the uppermost limit of the abdominal cavity. Inferiorly, extends down towards the inguinal ligament, which then stretches to the ASIS, the anterior superior iliac spine, to the pubic tubercle. This marks transition between the abdomen and the lower limb. Additionally, the superior margins of the pelvic girdle include regions of the iliac crest, and pubic symphysis. They all contribute to the lower boundaries that provide stability as well as attachment points for the abdominal muscle. The multiple layers of the anterolateral abdominal wall, each serving as a structural and functional role. The skin forms the outermost layer, providing protection and sensory input. Beneath it is the subcutaneous, also known as the superficial fascia, that's divided into the camper fascia, the fatty layer, and the scarpa fascia, the membranous layer. These are all below the umbilicus. Deeper is the three muscle layers, the external oblique, internal oblique, transversus abdominis. These are all enclosed by a deep fascia. They offer support and movement. There's also the extraperitoneal fat that cushions the abdominal organs. While the parietal peritoneum, this is the deepest layer, lies the abdominal cavity. Clinical application includes fluid accumulation, ascites. This can occur between the scarpa fascia and the deep fascia, leading into issues and potential surgical concerns. So on the right, you can see the layering over here from superficial on the left, and on the right, we have deep, showing you the layering of the muscles. The anterolateral abdominal wall is reinforced by three key muscotendinous layers. These provide strength, movement, and abdominal control pressure. The external oblique is the most superficial muscle with fibers running inferior medially in a hands in the pocket direction. This aids in the trunk's rotation and flexion. Beneath that layer is in the internal oblique that runs superior medially perpendicular to the external oblique. This provides additional support and rotation. Then the transversus abdominis is the deepest layer and it has the horizontally oriented fibers, and it plays a critical role for core stability as well as abdominal compression. Oftentimes, there could be weakness or tears in these layers that could lead to inguinal hernias. These are particularly whenever the transverse abdominis and the internal oblique, they form the conjoint tendon. That region is pretty weak. The wall consists of 5 paired muscles, which provide structural support. It protects the abdominal organs, it facilitates movement, it regulates the intra-abdominal pressure. The 3 flat muscles are the external oblique, internal oblique, and the transversus abdominis. They form the muscle layers of the abdominal wall, with the fibers running in different directions for strength and stability. The 2 vertical muscles are the rectus abdominis and the pyramidalis. They run along the midline, aiding in the trunk's flexion and tensioning the linea alba. And these weaknesses can lead into herniations. Oftentimes, excessive straining may cause the muscles to tear or even lead to abdominal wall dysfunction. Over here, you can see a visual of different layers: layer 1, layer 2, and layer 3. The external oblique, the internal oblique, and the transverse abdominis. Let's start with the rectus abdominis. This is a long paired muscle extending along the abdominal wall and plays a key role for trunk flexion, abdominal compression, and pelvic stabilization. It originates from the pubic symphysis and the pubic crest and inserts to the xiphoid process and the 5th to 7th costal cartilages. It's innervated by the thoracic abdominal nerves T6 to T12 and is characterized by a critical tendinous intersection, and this then creates a distinct six-pack appearance. Going back to what we said before is the diastasis recti. This is a clinical application common in postpartum where there's excessive stretching of the linea alba that causes separation of the rectus muscles, and this could lead to core weakening and also stability issues. The next muscle is the pyramidalis. This is a small triangular muscle located in the lower anterior abdominal wall. It originates from the pubic crest and inserts to the linea alba. This is where it functions to tense up the linea alba. However, it's insignificant in about 80% of individuals. It's oftentimes absent without any specific functional consequence. Clinically, this pyramidalis muscle isn't important at all. Its presence sometimes gets mistaken for abnormal masses or pathology in certain kinds of imaging. Surgeons might use this as a landmark during a midline dissection, but that's about it. The rectus sheath is a fibrous structure that encloses the rectus abdominis and the pyramidalis muscles. It is informed by the aponeurosis of the external oblique, internal oblique, and the transversus abdominis. It provides structural integrity and support. Running down the midline is the linea alba. This is a fibrous seam that extends from the xiphoid process to the pubic symphysis, and it creates this interweaving of these aponeurotic fibers. The linea alba is the preferred site for surgical incisions because it minimizes any kind of muscle damage and reduces bleeding. But the weakening of the structure due to that pregnancy or obesity can also cause complications. The next muscle here is the external oblique muscle. This is the most superficial of the three flat abdominal muscles and plays a crucial role for trunk movement, stability, and support. As it moves down medially, it transitions into the aponeurosis around the midclavicular line. This is the MCL region. This then interweaves at the linea alba and it forms a very strong central tendon. Functionally, it works as a digastric manner with another muscle, the internal oblique, on the opposite side, allowing for coordinated trunk rotation. Along the inferior margin, there's going to be this formation of the inguinal ligament. The inguinal ligament is the Popart's ligament, which then extends from the ASIS to the pubical tubercle. The key actions here are the bilateral contraction that involves a flexion of the trunk and compresses the abdominal contents, and also unilateral contraction where it rotates the trunk to the opposite side and it bends the trunk to the same side. As it extends medially, it transitions into the aponeurosis around the midclavicular line, the MCL. This then interweaving at the linea alba then forms a strong central tendon that contributes to core stability. Functionally, it works together with another muscle, the digastric muscle function, with the internal oblique on the opposite side. This facilitates trunk rotation and lateral flexion. On the inferior margin, we have the external oblique that forms the inguinal ligament, and also known as the Popart ligament, which then spans from the ASIS, the anterior superior iliac spine, to the pubic tubercle. Creates an important landmark. This muscle is innervated by the T7 to T11 spinal nerves, as well as the subcostal nerve. This provides essential control for core strength, respiration, as well as postural supports. Now let's take a look at the internal oblique muscle. This is the middle layer of the three flat muscles in the anterolateral abdominal wall. It originates from the thoracic lumbar fascia, the anterior 2/3 of the iliac crest, and the connective tissue deep to the lateral third of the inguinal ligament. It inserts onto the inferior regions of the 10th to 12th ribs. It also touches the linea alba. It also touches to the pecten pubis via the conjoint tendon. And functionally, the internal oblique plays a crucial role for trunk stability, so it allows for the actions of bilateral contraction because it compresses and supports the abdominal viscera, while also assisting in trunk flexion. The unilateral contraction allows for the same side rotation and lateral bending. So this works in coordination with the external oblique on the opposite side to facilitate any kind of twisting-based motion. On the right, you can see a visual of the external oblique and then the internal oblique. The internal oblique transitions into the aponeurosis near the midclavicular line, the MCL, and it contributes to that rectus sheath, which then encloses the rectus abdominis muscle, and it provides the structural support of the abdominal wall. The internal oblique also forms the conjoint tendon. This is a fusion of its aponeurosis with that of the transversus abdominis, and the tendon attaches to the pubic crest. This region then reinforces the inguinal region, so it helps prevent any kind of herniation. The muscle is innervated by the thoracic abdominal nerve T6 to T12 of the anterior rami, and also the first lumbar nerve. This then ensures that the motor control for core stability and also movement. Now let's take a look at the transversus abdominis. This is the deepest of the three flat abdominal muscles and plays a crucial role in core stabilization as well as abdominal compression. It originates from the internal surfaces of 7 to 12 costal cartilages and the thoracic lumbar fascia, the iliac crest, and also the lateral third of that inguinal ligament. It inserts onto the linea alba with the aponeurosis of the internal oblique, regions of the pubic crest, and also the conjoint tendon. The key actions here is to compress the abdominal contents. It helps you increase the intra-abdominal pressure during forced expiration or when you're trying to contract during defecation, as well as childbirth. And don't forget that it plays a role for core stability as well. So over here, a visual of the transversus abdominis. And then the aponeurosis formation also terminates, contributing to the rectus sheath. It encloses the rectus abdominis, and it's innervated by the T6 to T12 spinal nerves and also the first lumbar nerve. Now let's take a look at the rectus abdominis muscle. This one is a long strap-like muscle that extends along the interior abdominal wall. It lies within that rectus sheath separated by the linea alba. The origin of this muscle is the pubic symphysis as well as the pubic crest, and its insertion point is the xiphoid process plus the 5 to 7 costal cartilages. The main action here is that it helps with trunk flexion, bends the trunk forward, such as during a sit-up or crunches, as well as the abdominal compression, and it's innervated by the thoracic abdominal nerves T6 to T12 spinal nerves, and then the clinical application that we talked about is the diastasis recti. Over here is a visual showing you the origin and then the insertion. Here are 2 cheat sheets for you to look at and study. Helpful to know the origin, the insertion, and then the key action. And the innervation is also listed here as well. There's quite a bit of overlap. Most of them go from the T6 to T12 and the first lumbar nerve. And then we also have the external oblique, which is T7 to T11. The neurovasculature of the anterolateral abdominal wall is primarily supplied by the anterior rami of spinal nerves T7 to T12, which provide both motor and sensory innervation. The L1 anterior ramus bifurcates and splits into 2 key peripheral nerves. The iliohypogastric nerve, which innervates the skin above the pubis and the gluteal region, and the ilioinguinal nerve, which supplies the sensation of the medial thigh, the mons pubis, the labia, and / the scrotum for the males. There are several key dermatomes of the abdominal wall, include the T7 to T9 region. This region, which covers above the umbilicus, the T10 aligns directly at the umbilicus. The T11 and the L1 supply to the area below the umbilicus, and notably the L1 is responsible for the sensory innervation for the inguinal fold and the pubic region, which is clinically important to know. On the right, you can see a breakdown of the different dermatomes going from the T7 down to the L1 region. T7 to L1. Let's take a look at the blood supply of the anterolateral abdominal wall. It comes from both the superior and inferior epigastric arteries. This ensures adequate perfusion to the muscle overlaying structures. The superior epigastric artery is a continuation of the internal thoracic artery, which supplies the upper abdominal wall. The inferior epigastric artery arises from the external iliac artery, and that supplies the lower abdominal wall. And there are anastomoses with the superior epigastric artery near that umbilicus region. Additional contributing arteries include the intercostal and the subcostal arteries, which supply the lateral abdominal wall, the deep circumflex iliac artery that comes from the external iliac artery, and the superficial epigastric artery, which arises from the femoral artery. And that supplies the superficial layers of the lower abdomen. There's also extensive vasculature that plays a critical role in surgical procedures and certain kinds of trauma management. So any kind of disruption to these vessels could be significant and lead to ischemic damages or hematoma. Let's take a look at the venous drainage of the anterolateral abdominal wall. It involves both the superficial and the deep veins. They parallel the arterial supply. The first one is the thoracic epigastric vein, and it connects to the lateral thoracic vein to the superficial epigastric vein, forming an important collateral pathway for the venous return. There's also going to be the umbilical veins that drain into the portal system via the paraumbilical veins, and they become clinically important because of conditions such as the portal hypertension. That's when the liver fails and then changes to the blood flow occurs, causing increased blood pressure. The deep veins also follow a similar pathway, corresponding arteries, and ultimately drain into the internal thoracic, the external iliac, and the femoral arteries. Here's a snapshot of the key arteries, their origin, and their course of where they flow to. So the muscophrenic comes from the internal thoracic artery, the superior epigastric, and then we have the 10th and 11th posterior intercostal arteries and the subcostal arteries coming from the aorta. Over here we have the inferior epigastric artery that comes from the external iliac artery. The deep circumflex iliac artery comes from the external iliac artery. The superficial circumflex iliac artery comes from the femoral artery, and the superficial epigastric comes from the femoral artery as well. One of the clinical applications is the abdominal hernias. This occurs when the abdomen contents protrude through a weakened area in this anterolateral abdominal wall. They can be congenital or acquired, and their severity depends on the size, location, and what kind of contents are pushed out. Let's go over a couple of them. So the first one is the neonatal umbilical hernia. This results from the failure of the umbilical ring to close after birth, and this is usually seen in low birth weight infants. The hernias are usually small and tend to close spontaneously over time. We also have an acquired umbilical hernias. These are also more common in women and obese individuals. This is caused by increased intra-abdominal pressure and also weakness of the abdominal walls. They're oftentimes containing extraperitoneal fat or even peritoneum that might require surgical interventions. Then we have the epigastric hernias that run along the linea alba. These ones are between the xiphoid process and the umbilicus. The hernias contain lobules of fat rather than the bowel and can be very painful, particularly if there's any kind of compressed nerves. Then we have the Spigelian hernias, which develop along the semilunar lines lateral to the rectus sheath. They're more common in individuals over 40 years old and are usually also associated with obesity. There's the hernial sac, which is oftentimes covered by skin and subcutaneous fat. That makes it really challenging to diagnose. Let's take a look at the internal surface of the anterolateral abdominal wall. And it's covered by three key layers: the transversalis fascia, extraperitoneal fat, parietal peritoneum. These layers provide structural support and house important anatomical features. One of the defining characteristics of the internal surface is the presence of the 5 umbilical peritoneal folds that converge towards the umbilicus. The first one will be the 1 medium fold. This is the midline, and it contains the obliterated urcus. The 2 medial umbilical folds are bilateral, and they contain the obliterated umbilical arteries. Then we have the 2 lateral umbilical folds that are bilateral, and they cover the inferior epigastric vessels. You can see over here how they span over these structures, and they fold over these regions. There's the 1 median, there's the medial, and there's the lateral. The inguinal ligament and the iliopubic tract are the thick and fibrous bands that extend from the anterior superior iliac spine, the ASIS, to the pubic tubercle. These structures form critical anatomical boundaries. They allow the passage for hip flexors, as well as femoral nerve, artery, and veins. So what are some of the hip flexors? The psoas muscles, the iliacus, the quadricep muscles, the sartorius. The inguinal ligament is the inferior margin of the external oblique aponeurosis, and it functions as a reticulum or band that bridges the subingular space to support structures transitioning from the abdomen to the lower limb. There are 2 additional structures that reinforce this area. The first one will have to be the lacunar ligament, also known as the ligament of Gimbernat. It consists of a deeper fibers that pass posteriorly to the superior pubis ramus, and it forms the medial boundary of that subinguinal space. The second one will be the pectineal ligament, or also known as the ligament of Cooper, and is a lateral continuation of fibers along the pectinum pubis. And it plays a role for surgical repairs around the inguinal region or even any kind of these hernias. So over here you can see the structure of the deep inguinal ring, the outline of the retroinguinal space over here. We have the pectineal ligament right here. Over here we have the pectineal ligament and the lacunar ligament right here. Right at the base, right here. The iliopubital tract runs parallel and posterior to that inguinal ligament. This reinforces the posterior wall and the floor of the inguinal canal and ensures that there's structural stability. It plays a role also in types of hernia classifications. So clinical application and the significance is that in the inguinal and femoral hernias, direct inguinal hernias are protruded through the Hasselbalch triangle, a region that is a weak spot in the abdominal wall. Indirect inguinal hernias pass through the deep inguinal ring and they follow the path through the spermatic cord or along the round ligament. Then the last one are the femoral hernias, and they usually occur inferior to the inguinal ligament within the femoral canal. They're more commonly seen in women and also higher risk of strangulations. So over here you can see the different layers of the muscles on top, and over here with the inguinal ligament. We have several of the femoral vessels over here. And for this male structure, you'll see there's the convergence of the spermatic cord and testes that come from each of the layers. Let's take a look at the inguinal canal with a closer zoom up. The inguinal canal represents an oblique passage. It's about 4 centimeters long and is located in the inferior anterolateral abdominal wall. It serves as a conduit for many important structures. For the males, it contains the spermatic cord, which contains the vas deferens, testicular vessels, lymphatics, and the nerves. For the females, it carries the round ligament of the uterus. And regardless of the sex, you have both the inguinal nerve and the genital branch of the genital femoral nerve that transpasses through this region. So don't forget, these are 2 key nerves that branch through this area. And on the right, you can see a picture showing you the inguinal Hasselbalch triangle, shown in purple. The rectus abdominis muscle right left to it. And then over here, the inguinal ligament, shown in yellow, passes through the bottom inferior region of the triangle. The inguinal canal has 4 borders: the anterior wall, the posterior wall, the roof, and the floor, and each of them contributes to certain structures and functions. The interior wall is primarily formed by the external oblique aponeurosis, which has the lateral portion that's then reinforced by the internal oblique muscle fibers. The posterior consists of the transversalis fascia, with additional support from the inguinal phalanx. This is also known as the conjoint tendon. This is a fusion between the internal oblique and the transverse abdominis aponeurosis. So that juncture between the 2 aponeuroses is the inguinal phalanx. The roof then varies along in length. Laterally, it is formed by the transversalis fascia, while centrally it is supported by the arching fibers of the internal oblique and the transverse abdominis muscles. And then the last part is the floor. This is composed of mostly the iliopubital tract laterally and the inguinal ligament centrally. And this serves as a protective gutter for structures to pass through. So here on the right in letter A, you can see the external oblique, and then the inguinal ligament and the linea alba. In letter B, underneath that layer, we have the internal oblique, the conjoint tendon. Over here, transverse abdominis, and then the conjoint tendon. And then we have deepest is the fascia transversalis, and the deep inguinal ring over here. The hepatic portal vein HPV serves as a primary vessel of the portal venous system. It transfers most nutrient-rich but oxygen-poor blood from the GI tract, the pancreas, the gallbladder, and the spleen to the liver for processing. It forms by the union of the superior mesenteric vein and the splenic vein. They come together, and occurring at the posterior to the pancreas, but it is anterior to the inferior vena cava. The inferior mesenteric vein, IMV, drains into the splenic vein, 60%, and then the SMV at about 40%. There are occasional variations where all 3 of these veins converge directly to form the HPV. This is a system that's crucial for liver function, detoxification, metabolism, and it is kind of clinically applied in conditions such as portal hypertension, which can result in certain kinds of varices. And we'll talk about that very shortly. On the right, you can see this is an overview of some of the key anastomoses provided by the collateral circulation, and in cases where there is obstruction in the liver or the portal vein. The regions that are highlighted with a dotted line represents regions where there are common varices that occur, and we'll talk about that in the next slide, but includes regions of the esophageal vein, regions of the paraumbilical vein, regions of the rectal veins, and regions of the retroperitoneal veins, the Retzius veins. The portal system anastomoses. These serve as collateral pathways of connecting the portal venous system to the systemic venous system. And this is very important in conditions like portal hypertension, where the blood flow gets redirected due to any kind of liver damage or liver dysfunction. There are four key anastomoses that we're going to cover. The first one is called the esophageal anastomoses. This is when the left gastric vein from the portal system communicates with the esophageal vein from the systemic system, and it drains into the azygos vein. Whenever it is engorged, this can lead to the esophageal varices, and this can be a life-threatening condition that causes upper GI bleeding. So on the right, it's shown here in the number 1. This is the first kind of varices. This is the esophageal anastomoses varices. The second one is the rectal anastomoses. This is the superior rectal vein portal system when anastomoses with the middle and the inferior rectal vein system. This then drains into the IVC, and engorgement at this site can also mimic issues like hemorrhoids, but with significant amount of bleeding. Over here on the bottom, in letter number 2, you see this is the region of the inferior rectal veins. Number 3 is the paraumbilical anastomoses. The paraumbilical veins from the portal system connects to the epigastric veins from the systemic system, and it drains into the SVC and the IVC. Portal hypertension then leads to a condition known as the caput medusae, and this is a distinctive dilation of the regions of the paraumbilical vein. It resembles a medusa-like head, and it's shown here, kind of like the head of a snake. And the last one is the retroperitoneal anastomoses. This is the colic and the splenic and the portal veins from the portal system communicating with the retroperitoneal veins of the systemic system. And it drains into the IVC, the inferior vena cava. And this pathway can become enlarged, then leads into retroperitoneal varices, causing tons of bleeding and portal hypertension. All right, so over here, the condition of portal hypertension, this refers to an increased pressure within the hepatic portal vein, primarily due to cirrhosis or damage to the liver, which causes fibrosis and scarring that obstructs the blood flow. Other causes may include right heart failure or caused by the Buch-Chiari syndrome. And Buch-Chiari syndrome is a very rare liver disorder that usually is caused by issues such as a factor V or blood clotting mutations in protein C's, protein S's, or antithrombin. And in some cases, it could be also from a tumor or cyst compressing against the hepatic vein. And it's also, in some cases, unidentifiable causes. Non-identifiable causes are found. But when the hepatic portal vein is obstructed, the venous pressure begins to rise. This will then force the blood to divert through portal systemic anastomoses. This elevated pressure will then lead to a development of these varices, which can then rupture and cause life-threatening bleeding because it's forcing the blood across. So as we said before, the common varices locations are as follows: the esophageal varices, the caput medusae, the rectal, and the retroperitoneal varices. Those are the four key ones. On the bottom, I just wrote out how the blood flow goes. So the left gastric vein goes to the esophageal vein, which then normally drains into the azygos vein. The paraumbilical vein goes into the epigastric vein and it goes into the SVC-IVC. The superior rectal vein goes into the middle inferior rectal veins, and they go into the IVC. And then for the retroperitoneal anastomoses, it's when the colic and splenic and then the portal veins directly communicate into the retroperitoneal veins and then drains into the IVC. The aberrant hepatic arteries refer to anatomic variations in the origin or the course or the branching of the right and left hepatic arteries. So recognizing some of these variations can be critical to understanding hepatobiliary and gastric surgeries, and you avoid any accidental ligation. So the first one is called RHA, right hepatic artery. This is going to be the origin, is going to be the hepatic artery proper, which is the branch off of the common hepatic artery. The aberrant, in most cases, is going to come from the superior mesenteric artery. And why is this important is that during clinical application in cholecystomy, when you're removing the gallbladder, there could be an aberrant RHA that could be mistakenly ligated, that can then lead to liver ischemia and then damage to the liver. That's also why in liver transplants it must be very carefully done, as well as certain kinds of pancreatic duodectomies, or removal of the pancreas and the duodenum. The next one is the left hepatic artery, LHA. The normal origin is also going to be the hepatic artery proper, and most of the common aberrant arises from the left gastric artery. An aberrant LHA may be injured during gastric surgeries, especially in surgeries that involve the lesser curvature of the stomach, such as gastronectomy or fundoplications, which is basically treatment for GERD, gastroesophageal reflux disease. And usually what happens is the surgeon will wrap up the upper portions of the stomach, the fundus, around the lower esophagus. And this wrap will then strengthen the lower esophageal sphincters, the LES. So on the right, you can see two pictures. The letter A, this is the typical patterning of the branching of the celiac trunk of the hepatic arteries. So the right hepatic artery, the left hepatic artery over here, cystic artery, and it comes off the common hepatic artery. Over here, in this case, on the letter B, the right hepatic artery may originate directly from the superior mesenteric artery. And letter C, the left hepatic artery may originate from the left gastric artery right here. And letters F, G, and H shows you the percentages of folks in letter F, the 24%, where the right hepatic artery in relationship to the common hepatic duct, you can see the right hepatic artery is going to be in front of the common hepatic duct. And letter G, 64% of patients, the hepatic artery, the right hepatic artery goes underneath, while the left hepatic artery goes over the common duct. And then letter H in 12, you'll see the hepatic artery splits directly from two different vessels, and the right hepatic artery goes by itself, and then the hepatic artery comes by itself. And then that becomes the left hepatic artery. So there are very many rare variations, and this can be tricky because when you're cutting around the common hepatic duct, you do not want to damage any of these vessels.